Ladies and gentlemen, dear friends, welcome to the new series of webinar of the International Society of Gynecological Endocrinology. As you know, it's one habit that we have to organize this series of webinar, waiting the beginning of our next meeting in May in Florence. This first webinar will be dedicated to an important chapter of gynecological endocrinology, which is the hormone-dependent and independent aging of the pelvic floor, external genitalia, and skin. And we have two masters this afternoon with us. One is Professor Tommaso Simoncini, who will speak about menopause and aging of the pelvic floor from patophisiology to clinical management. And Tommaso Simoncini is Professor of Obstetrics and Gynecology at the University of Pisa, Director of the Division of Obstetrics and Gynecology, and he works with international scientific societies publishing international guidelines dedicated to the best medical practice for the diagnosis and management of female disease. The second speaker is Professor Marck Brincat. He is well recognized and he will speak about a topic that he knows very, very well, who is skin and vulval changes during the menopause transition, management and treatment. And Professor Marck Brincat from Malta, he is a consultant obstetrician and gynecologist, clinical chairman and head of the department, resident professor in obstetrics and gynecology, and associate dean and professor in medical education in London. Then, dear friends, we will have a further presentation of Tommaso Simoncini, then that of Marck Brincat, then we will have the general discussion. You can write your question on the question and answer, and I will take care of them, and I will introduce your question to our speaker. Then, Tommaso, please, you have the microphone.
Thank you so much, and I'm going to share my presentation. I hope you can see it.
Yes.
So thank you so much for the introduction, Professor Genazzani, and for being always so super active in organizing these webinars. It's an honor for me to be here today and to speak together with Professor Brincat. So I'll try to address an interesting topic. I think a topic that is overlooked. So how menopause affects the pelvic floor and whatever works around the pelvic floor, particularly the urogenital tract, and how this impacts our management at the menopausal transition. Let me start with a few introductory slides to show you sketches of my city, the city where I work, Pisa. This is the beautiful Leaning Tower. Professor Genazzani has worked and chaired the department that I'm now working in for so many years. So these are very nice images. This is actually where I live in Lucca, just to give you a glance of where we are used to work in Tuscany. So it's a beautiful environment. So since we are a multinational audience today, it's nice to see it. And this is me with my family and my hometown, and also the dogs, actually. So just as a brief personal introduction. So let's start with the scientific part. So the menopausal transition is a complex process. It involves a lot of modifications and changes, and one of them is urogenital atrophy, which is a part of our clinical practice. Now, what we have in our hands is a lot of evidence that suggests and shows that the menopause is a risk factor for the development of pelvic floor disorders as a whole. And the symptoms and severity increase significantly after the menopause. So this is the bottom line. So we know the clinical association. There's a lot of urogenital changes across the menopausal transition. But the changes that are attributable to the menopause overlap with those changes which are more progressive and are to be attributed to aging in general, so not specifically to the hormonal modifications of the menopause. And these both affect the physical, physiological, and microbiological characteristics of the genitourinary tract. Let me show you a slide where, I've tried to summarize the changes in the external genitalia that happen around the time of menopause. There's a lot of modifications. Some of them have to do with the structure of the parts of the external genitalia, like the amount of collagen or elastin fibers, the thickness of the epithelium, the amount of muscle cells, vascularization, which then lead to those changes that we are able to recognize, the changes in the labia, in the introitus, in the hymen, the urethral hiatus, and all the clinical modifications that we are able to measure. Now, this is just the tip of the iceberg. Because all these changes also happen not just inside the genitalia, but also at the level of the low urogenital tract and in general, although it is not that studied in the pelvic floor. So this is the reason why a few years ago, the acronym of GSM, or genitourinary syndrome of menopause, was created. So to indicate that at the menopause, not just the vagina was changing, but there was something more that extended at least to the bladder and to the lower urinary tract, which is very appropriate. And it's probably still a limited concept, but it has the merit of broadening our view. So since then, there have been several publications in this area, and the attitude of putting together in terms of what changes at the time of menopause, the symptoms, the signs and symptoms, and the clinical manifestations of the external genitalia, the urological tract, and also on sexual function has become, I think, very common. So we all know now that when things change in the vagina at the menopausal transition, in reality, there is also changes happening at the vagina, in the urethra, in terms of urethral function, and some of these changes also affect sexual function. It's not just the atrophy of the mucosal thickness. Anyways, up to now, we are still looking at the fact that the symptoms associated with the genitourinary syndrome of the menopause are underreported, underrecognized, and mostly undertreated. And I think that the undertreatment is largely due to the fact that as gynecologists, we are very accustomed into the treatment of vaginal atrophy. We are less used to recognize and therefore diagnose and treat the problems in the lower urinary tract. And this will be the focus of this presentation. So let me start with the discussing a little bit of how the bladder and the lower urinary tract changes across menopause and aging. So common symptoms, common manifestations after the menopause that we see in postmenopausal women, even early after the menopause, are dysuria, the urethral syndrome, painful manifestations in the bladder, trigonitis, cystitis, the development of urinary incontinence, particularly stress urinary incontinence, but also very often the change in the function of the bladder that can reach the level of an overactive bladder. This is very much associated with the menopausal transition. And another thing that happens very frequently after the menopause is that women start developing recurrent urinary tract infections. I think everybody here in this audience recognizes that it's much more frequent just after the menopause than just before the menopause. And actually, painful bladder symptoms, so symptoms of a painful bladder, are very often recognized after the menopause in women with recurrent urinary tract infections. And also postcoital cystitis and postcoital bladder pain is also much more common after the menopause than before the menopause. This is also this is very common and very important. And in parallel, some of the we are very familiar now with the sexual dysfunction that women encounter at the time of menopause. But we are a little bit less aware that some of the reasons why there might be problems with the sexual activity in women might also be due to the fact that there may be a pelvic floor dysfunction. For instance, the desire could be less because of the fear of leakage of urine during intercourse. Arousal could be less because also of the change in the bladder and the vagina, which may alter the sensitivity of the tissues here. The orgasm platform is also due to the participation of the muscles around the vagina. And if you have a painful bladder, and if you have dysfunctional muscles in terms of dyssynergic muscles at the pelvic floor, it can be more difficult to reach orgasm. And of course, if you have pain, this is one very major reason why not having orgasm or pleasure during sexual activity. So if we put all these concepts together, atrophy of the vulva and the vagina is one process. Changes in the bladder and the urethra are another process. There's also in the middle that joins in some ways and alters both processes. A lot of changes in the microbiological colonization of both the vagina and of the bladder. All these impacts the symptoms of the genital urinary symptoms or syndrome of menopause. So when we talk about the urological and genital atrophic changes, so we know that when you lose estrogens, you lose the thickness of the vaginal epithelium. We know a little bit less of the role of androgens that are lost more progressively and not specifically in association with menopause. But there's a lot of changes in terms of loss of estrogens and androgens that is very likely to affect also the lower urogenital tract. For instance, these could facilitate a lower content of glycosaminoglycans and hyaluronic acid in the bladder. And this is one very good reason why the bladder becomes more sensitive to infection. The vascularization of the urethra and of the muscles around the vagina and the urethra, which is very important for orgasmic function and urinary continence. The increased amount of collagen fibers in the urethra and in the bladder muscles could also make the bladder less effective in functioning. Changes in receptors, particularly muscarinic receptors, which are very important in the bladder for the voiding function. So all these things are affected by hormonal changes at the time of the menopausal transition. And on the other side, there's also the big item of the urobiome and of the microbiological colonization of the vagina. In this graph, you see how much overlap there is between gut microbiota, so the bacteria that are living on a daily basis in the gut, and what is the overlap between the vaginal and the bladder microbes. You see that the vagina and the bladder share a much bigger number of bacteria. So there's a common exchange between bacteria in the vagina and in the bladder. But the gut is actually something that is much more invading the vagina and the bladder with E. coli and other similar bacteria. So we do know that in the vagina, when women turn menopausal, it's not just a problem of a thinning of the endometrium of the vaginal mucosa. There is also a change in the bacterial composition because of the lack of acidity of the vagina and of the many nutritional components that influence the colonization of bacteria. We also know that if you re-administer hormones through the vaginal route or through the systemic route, the colonization of the bacteria change, and this has an impact also on vaginal symptoms. So it's not just the vagina changing in response to estrogens, it's also the macrobiological composition of the vagina, which helps having a healthy and functional vagina. We know a little bit less about what happens in the bladder with bacteria, but for instance, we do know that in women that have urge urinary incontinence, so they have lower urinary tract symptoms, there are urobiome differences as compared to the women that have no symptoms. So the specific composition in terms of the bacteria that we find in the bladder has an impact on the development of symptoms, it looks like. So any change associated with the menopause that drives a different colonization of bacteria in the bladder is well expected to have a potential impact on the development of urinary symptoms. And in the end, there's also a big interrelationship between the brain and the peripheral nervous system and the bladder. The bladder is a highly controlled organ. And through aging, there's a loss of muscle fibers, so the bladder becomes weaker in terms of muscular strength. And this is particularly happening in the detrusor muscle, so in the muscle that contracts and empties the bladder, but also in the urethral sphincter, which is, of course, more important for continence. There's changes in the central and spinal control of the bladder, which becomes progressively less precise, such that the bladder can work a little bit more independently from the real need of voiding. And mostly, there's a developing process involving inflammation and oxidative stress and ischemia of the bladder, which changes a lot the bladder function. We nowadays talk more specifically of a neurogenic inflammation to express this concept. And this neurogenic inflammation is the vast and complex set of modifications in terms of production of radical oxygen species, of oxidative stress, inflammatory cytokines, and devascularization of the bladder that in the end lead to loss of sensitivity of the bladder, on the development of excessive contractility of the bladder, which can lead to incontinence, and in the detrusor muscle function impairment, which can lead actually to voiding dysfunction, so to make women less able to empty the bladder. And as you can see on the left side of the slide, menopause and GSM are actually identified risk factors for this neurogenic inflammation. So the menopause impacts the aging and the deterioration of the bladder. And there's a lot of studies that show that there's also ischemic and oxidative stress happening in the central and peripheral centers that control the bladder. So it's not just the bladder aging, it is also the centers in the brain and in the peripheral nervous system that control the bladder that age. And they are less able to respond appropriately to the usual filling and emptying circle that needs to happen in the bladder. So in the end, these changes facilitate the development of dysfunctions that are typically throughout the aging process, the reduction of bladder capacity. So the bladder is a little bit more rigid and tends to distend less efficiently. So it becomes filled up much more quickly. And if you have more sensitivity in the bladder, which can be facilitated by infections, for instance, then for a very small amount of filling, then you have a stronger sensitivity and you feel the need to go and void. You can have the detrusor overactivity, which is a different type of phenomenon, which is the uncontrolled contraction of the detrusor muscle, which pushes urine out and stimulates urge urinary incontinence. And you can also have in parallel the impairment of bladder emptying. So you have a rigid, more sensitive bladder, which is actually a weaker bladder. So on one side, it tends to give the stimulus to go to the bathroom. But on the other side, when you go to the bathroom, you're not able anymore to empty the bladder efficiently. And this over-distends the bladder and can increase the sensitivity of the bladder itself. There's also changes in the urethra, which are very important. These are well known and they have been studied since many years. All the tissues around the urethra, the vessels, the collagen tissue, the muscles, also the muscular layers of the urethra, tend to change across the menopausal transition. And there's a lot of things that facilitate a reduction in the urethral closure pressure, as it is called. So the pressure that you have at baseline in the urethra, which offers a certain degree of resistance to the passage of urine. The epithelium thins, blood flow decreases, so you have less engorgement around the urethra. You have less collagen. You have a reduction in alpha-adrenergic receptors, which are very important in the bladder sphincter muscle. Slowing of nerve conduction, so it's less efficient, the transmission of the signal to the muscles to contract and close. And you may have less urethral support, which facilitates stress urinary incontinence. Therefore, the urethra can be impaired in terms of function because of these structural changes. So if we look now with a different set of informations in mind to GSM, and we look at the urinary part of GSM, then we see that genital discomfort can well be associated with bladder pain, bladder dysfunction, bladder incompetent bladder emptying. Dyspareunia can be also associated with bladder pain. Urinary incontinence, of course, is simple. But also nocturia, frequency and urgency. So the fact that you have a more sensitive and a smaller bladder, so that it drives the need to go more frequently to the bathroom, maybe during the night, maybe at the time when a woman also experiences hot flashes and sweating. Voiding symptoms and recurrent urinary tract infections, and all the painful symptoms that can be spontaneous or associated with coital activity are typical areas where it's more the urogenital tract changes that provide the discomfort to the menopausal women. So having said that, we need to understand that when we talk with early and later postmenopausal women, we also need to be aware of the presence of pelvic floor dysfunctions. And if we look at the age ranges, urinary incontinence, for instance, is so much common after the menopause. And there's some slight changes, as you can see, when women age. The amount of women that have urge urinary incontinence or mixed, therefore, which means the presence of both urgency urinary incontinence and stress urinary incontinence increases, while stress urinary incontinence becomes less frequent. This is actually the consequence of that neurogenic inflammation that I was discussing before. So it's the bladder that becomes over and over less effective in voiding and more sensitive and reactive to being filled and to irritative stimuli like infections. So this is very important because it is very troublesome for women. This is the frequency of urinary tract infections in postmenopausal women. You can see that it's actually, of course, throughout age ranges that include also premenopausal women. But if you concentrate on the postmenopausal, so from 50 and above, you do see that there's in females, there's a typical increase and direct increase in the frequency of urinary tract infections with peaks after the age of 80, where urinary incontinence and the use of pads becomes more frequent in the population. So why is this fact of the infection so important? Infections, we are used to think about infections of the urinary tract as the cause of cystitis. So you get the colonization by E. coli, you develop a cystitis, you have a lot of pain, burning, you have to rush to the bathroom, you take your antibiotics, it goes away. This is the young woman cystitis. But after the menopause, and particularly after the age of 60, everything becomes more subtle. And the colonization of the urinary tract is more frequently low dose or low frequency colonization. So you have less bacteria. And this less frequently drives the development of a full cystitis with even blood loss. You have much more commonly the development of a chronic release of inflammatory substances by these bacteria that enter the bladder and become resident in the bladder, which inflame the bladder wall, and particularly that signals through specific signaling receptors, for instance, the Toll-like receptor 4, to the epithelial cells of the bladder, which are drivers of sensitive stimuli, to the nervous system, through the sensory neurons of the nervous systems, providing inflammatory stimuli and responses, which means more sensitivity, more contraction, more incontinence, more frequency, being more frequent, and so on. That's why postmenopausal women with urogenital atrophy tend to have in such a frequent way urgency, painful bladder, and urethra, and frequency, and nocturia, because their bacteria coming from the gut and colonizing the vagina and therefore the bladder drive the stimulus. So we need to be aware of this, and we need to be aware that there are strategies to reduce the colonization of these bacteria of the bladder, and this is the only way to drive down these symptoms, which are not to be treated like a common cystitis as we do in the younger ages. And there's a lot of overlapping symptoms, so we need to understand very well what we are treating in that specific woman that we are approaching. There's overactive bladder on one side, which can be associated to infections, but can also be idiopathic. There can be urinary tract infections, and we need to be aware of the amounts of bladder or the colony-forming units that you have. You can have also some rarer manifestations of painful bladder, like interstitial cystitis. You can also have cancer. Some cancers of the bladder manifest themselves as with lower urinary tract symptoms and incontinence or overactive bladder. So we need to be aware of this and not disregard all the urinary symptoms as something that needs to is natural because the woman is postmenopausal. So let me move briefly towards the end of the presentation by talking a little bit about the therapeutic approach. So if you have followed me, I think you have appreciated that the therapeutic approach of the GSM involving lower urinary tract symptoms is not really easy, because you have a lot of things going on. You have infections, you have changes in the bladder, you have changes in the nervous system. You may have comorbidities like diabetes and peripheral neuropathies influencing the bladder. So you need to be aware of everything that goes on. You may have also, I haven't discuss this because of time, but you may have also pelvic organ prolapse, which alters in an anatomical term the ability of the bladder to function. So it's always a matter of being in equilibrium between many conditions, and restoring the physiology of the urogenital tract is difficult. But it's feasible, and it can be approached by mixing up concepts. So the changing concepts needs to be that us as gynecologists need also to be aware of the urogenital tract, and therefore not limit ourselves to treating vaginal atrophy with estrogens or DHEA or anything else that we have to approach vaginal atrophy. But we need to be also able to play with prevention of infections using mannose, cranberry, hyaluronic acid to protect the bladder, using antimuscarinic therapy to modify the bladder function, to be aware of the fact that sometimes we need to be more proactive with our women in proposing hormonal treatments, also local treatment like vaginal estrogens, in order to promote a change in the vaginal environment, which protects them from the colonization of bacteria of the bladder, and therefore from bladder symptoms. And that if a woman has an overactive bladder, if you use both estrogens and specific therapies like antimuscarinic or alpha-adrenergic drugs that are directed on the bladder wall, these will synergize and you will have a better response. And for this, we have quite solid data. So we need to be very active in treating urgency symptoms, because urgency is always a manifestation of bladder irritation, bladder infections, and bladder aging. So we need to concentrate on that, because this type of symptom is really annoying and impairs quality of life a lot, even more than vaginal atrophy, because vaginal atrophy is very often important, mostly for women who wish to conserve sexual activity. But for women that are a little bit more further down in their life, if sexual activity is not happening anymore, vaginal atrophy may not be as important. But if those women need to run to the bathroom every hour, hour and a half with urgency, and they lose urine, then their social life is impaired. So this is much more impacting on a woman's life. Good news is that there's a lot of things going on in the pharma environment. There's a lot of new concepts that are in the pipeline. Some of them have proof of concepts. Some of them have already animal data. These new concepts will enter the therapeutic arena in a few years. So sooner we will be able to manage more drugs to help our postmenopausal women that have lower urinary tract symptoms. And we need to be ready to uptake these therapeutic agents. So we don't have to make the error of considering these drugs for the urologist, because the urologists mostly treat prostate cancer and bladder cancer and kidney cancer. There's only a few urologists who do functional urology and are used to treat the overactivity of the bladder and painful bladder symptoms. It's mostly in the hands of us gynecologists, and we need to keep it that way. So the key points of GSM and the lower urinary tract symptoms. Both aging and menopause affect the urogenital tract in postmenopausal women. So menopause has a role, but also aging. Urinary problems in postmenopausal women with GSM are underreported. So we need to inquire, particularly on urinary function and bladder pain. Atrophy and chronic inflammation are the basis of both lower urinary tract symptoms and some of the GSM symptoms in the vagina. Hormone therapy is the mainstay of medical treatment, and there's new promising hormonal drugs that will come very soon. But for those women who develop these lower urinary tract symptoms at menopause, we need to reestablish an hormonal environment, which is more physiological in the vagina. But the key is to have a personalized and synergistic therapeutical approach to restore urogenital physiology. And this is very important. So we need to know the problems to do the right diagnosis, and therefore we will be able to manage things more effectively. So this is the end, and I'd like to thank again Professor Genazzani and ISJ for organizing this beautiful webinar. Of course, I'll be glad to take questions at the end of the session. And let me just show the invite for our Florence meeting early next year, certainly in presence. Thank you so much.
Thank you, Tommaso, for the beautiful lesson. It was a master on an area which is touching really the daily life of millions and millions of women. And then now we will move to the second talk, which will be also touching a very important area, is the skin and vulval changes during the menopause transition, also management and treatment. And I invite Professor Marck Brincat to start his presentation. Thank you, Mark. And I remind to all of you, please send your question. In the question and answer, you can write your question and I will take care of them and I will introduce your question to our speaker at the end of the Professor Brincat presentation. Mark, you have the microphone. You can share your screen. Thank you. Go on presentation. Okay. Thank you, Mark.
Thank you. So my first slide you have seen, that's the invitation Professor Simoncini showed to the meeting in May. And thank you first of all, Professor Genazzani, for inviting me to participate in this webinar. Thank you, Professor Simoncini and David as usual. So I'm just going to take off from where Professor Simoncini finished. And there will be some repetition. In my case, I'm going to concentrate mostly on the skin and vulvar changes during the menopause transition, and we'll discuss some aspects of management and treatment in our day-to-day practice. Okay, right. I'm trying to get this thing to work. Okay, good. All right, these are my disclosures. And we're going to start a bit with the skin, and I'll be very brief with the skin. We know that the skin is composed of dermis and epidermis. The dermis is mostly composed of collagen, and you've seen slides of the dermis before. I don't know if you can really see the slide properly, but this is some of the early work that showed that essentially connective tissue is connective tissue everywhere, be it connective tissue in the skin, be it connective tissue in bone, be it connective tissue in the carotid artery, for example, and also, of course, in the vagina and vulva. And you can see from this slide that irrespective of your age, there is a decrease in skin collagen content, in this case, in the first 5 years, 5 postmenopausal years, and then this levels out. This type of decrease is very, very similar to the sort of decrease you see in bone, which is now very, very well known. And this is some of the early work we had done when I was a Professor Studs unit at King's College. You can see that in women who've been on hormone replacement therapy for at least 2 years, the skin collagen content was maintained. And this was the first suggestion that it was possible to increase your skin collagen content from here to normal premenopausal levels with under 2 years of treatment of estrogen replacement therapy. Here, on the other hand, is a prospective study from the same group, and where we were giving a hormone implant at base and then repeating it at 6 months. And all the time, we're measuring the actual skin thickness by radiological methods. Now, skin thickness also includes your glycosaminoglycans as well as your collagen bundles. And you can see that there's an increase, a linear increase virtually in the first 6 months, and this leveled off later. So, of course, you don't keep on increasing your skin thickness ad infinitum, but you, in fact, leveled off. So here is further evidence that you could actually increase your skin thickness with hormone replacement. We now know that it's not just the dermis that improves the skin, but also your epidermis. We know that there are changes, which we will describe later, which Professor Simoncini has shown, that your collagen bundles get thinner, they get sparser, the amount of hydration in the dermis itself, glycosaminoglycans, lose their water carrying capacity, and this is the basis for your dry, thin skin that happens after the menopause, which is not strictly speaking age-related, which is independent. But in addition, there's also problems with the epidermis happening, and we know that the epidermis gets thinner, the ureter pegs get flatter, and this is more likely to lead to trauma, and we get easy bruising. Now, Phillips and Sartor, these are French and French, another French author called Frachimont, Pierre Frachimont, were able to show that even wrinkling can be prevented. Now, a lot of wrinkles were always a big problem. Skin wrinkles were always a big problem because there's a certain amount of solar damage that occurs. But we do know now that skin wrinkles can be prevented in women who are estrogen replete. And the biggest example are women who are overweight, as you can see from your old Renaissance paintings, and Florence is full of them, where your nice chubby women have got nice skin. And this is because postmenopausally there is peripheral conversion of estrogens. So this was early evidence as depicted by our early portrait painters. But also we know now that if you are in early enough, you can prevent those skin wrinkles that are due to estrogen depletion. And one of the reasons is because the water holding capacity of the dermis is improved, as is that in the epidermis, and this puffs your skin out and thus prevents wrinkling. The keratinocytes themselves in the epidermis increase in proliferation, and you get less dry skin once you give estrogens. This is because the epidermis, as well as the dermis, has got estrogen receptors, both ERA and ARB in epidermal receptors. And we obviously studied skin on the abdomen and on the thigh, but what is true for skin is also true for the vulva and for the vagina. Not only is the dermal hydration improved, but epidermal hydration, and these are thickly packed cells in the epidermis, unlike the dermis, which is much more loosely packed, but nevertheless, they are hydrated. The cells vary in size. With postmenopause, you get, instead of your average 5 to 6 layers of epidermal cells, you get about 3 layers, and they are thinner, more densely packed, less well hydrated, drier, and more ready to rupture and crack. So we just leave skin as an aside, as an example, and remember that skin is the largest organ in the body. It also includes naturally the vulva and the vagina and the base of the bladder, as well as the rest of the bladder, but the base of the bladder in particular is derived from the Mullerian ducts and is similar to the upper 2/3 of the vagina in origin. The bottom 1/3 of the vagina and the vulva are derived from the perineum. In both cases, you've got the highest density of estrogen receptors in the body. So these are very highly sensitive to estrogens. So it is no surprise then that the vulvar-vaginal atrophy and the genital uterine syndrome have had special attention, and the definition by Portman you have already seen in the previous presentation, and this is a simplified version of it. Basically, any signs and symptoms in the bladder, vagina, and vulva that are associated with a decrease in estrogen production during the menopause are referred to as vulvar-vaginal atrophy and genitourinary syndrome, GSM. GSM is genitourinary syndrome of the menopause, right? So this gives you an indication of what we're talking about straight away. Where do these changes occur? They occur in these areas which have got the highest concentration of estrogen receptors, like the labia, for example, the clitoris, the introitus, the vagina, the urethra, and the bladder. Now, there's a big difference between the incidence on close questioning and reported incidents. As you have heard from Professor Simoncini, most women just bear up and do not volunteer that they've got problems. But if you ask them in detail, then take a proper history, which is the hallmark, which is the basis of our medical practice, a proper history and examination, then you will find that up to 50% of postmenopausal and menopausal women will develop signs and symptoms of GSM. So the incidence is there, we have to look for it. A lot of discomfort is endured unnecessarily by our women. Signs, this is once again a summary of what you've seen earlier. Well, decreased moisture, we have spoken about this dryness, which is characteristic. Incidentally, it's characteristic of women that are menopause in their eyes as well. Dry eyes and dry vagina go together, but the dry vagina is more pronounced. And there's also dry skin. There's decreased elasticity, which means that there's a bigger propensity to having small cracks, small lesions, small abrasions, maybe with intercourse, simply because the skin is less elastic. And decreased elasticity also increases the instance of prolapse. Prolapse does not happen because your perineum is, your pelvic floor is elastic. It happens because of a loss of elasticity. It's the opposite. Most people think the prolapse happens because of increased elasticity, and this is not so. You've got a decreased elasticity, the whole thing breaks down, and you get a descent of your bladder, say uterus or your rectum. The labia minora resorb, they become smaller, they shrink and they are painful. There is pallor and there's bruising. The vaginal ruga becomes flatter, more liable to undergo fissures. There's more fragility, more small bruising. The urethra itself, it's a very important sign. The introitus itself very often either everts or is bruised or has an erosion. Cystitis-like symptoms you've heard about, and we can get recurrent urinary tract infections, but it's important to realize that not all cystitis postmenopausally is a result of infection. If very often people are given antibiotics for no reason whatsoever, simply because they've got cystitis-like symptoms, which is due to the fact it's got increased keratinization and abnormal epidermal activity in the base of the bladder, which causes inflammation and cystitis. Not all inflammation is due to infection. Etiology of all these symptoms boils down to the same thing. There's a loss of your non-collagenous hydrophilic glycosaminoglycans. Now, when we say hydrophilic, we're talking about a molecule that weight for weight can absorb something like 90% of it is water. So it's extremely hydrophilic. And there are glycosaminoglycans and glycosaminoglycans. There are micropolysaccharides here. There are some which with age become less hydrophilic. They change. This happens in cartilage as well, and we've done some work on cartilage. Another interesting etiology for this is the reduction in new blood vessel formation. Estrogens are a potent drive to angiogenesis, so without estrogens, you get less new blood vessel formation and therefore a reduced blood supply. And both these lead to atrophic changes. So if your estrogen receptors don't have any estrogens, they're not responding to estrogen receptors, there's no estrogen, they atrophy. But you also get this reduction in angiogenesis and reduction in blood supply, leading to general shrinkage of the area in question. As usual, how do we handle it? We're going to go to some clinical management now. A good history and a good examination are essential. A well-woman health check with a pelvic exam, a urine test, because although this might not be so, there's still a propensity to urinary infections, and bacteriology needs to be carried out. So there is cystitis, might be negative, but it's good to know. A cervical smear, nowadays we're using brush smears more than anything else. But even women who've had hysterectomies, we encourage people to consider doing a pap smear, because you never know what the vaginal vault might have. There might be some atrophic changes, there might be some fungal infections, or sometimes, rarely, some residue from some cervical disease that had been happening prior to the hysterectomy. Urinalysis, and then we consider treatment. And treatment is divided into non-hormonal and hormonal for vulvovaginal atrophy and genitourinary syndrome of the menopause. So we will talk first about non-hormonal treatments which are gaining popularity. And the first are these vaginal moisturizers. There are quite a number of vaginal moisturizers on the market. Mostly they've got glycosaminoglycans in them, and they've got hyaluronic acid in them. And the idea is to restore, is to reduce soreness and restore moisture in the vaginal area. We've got Regel here, it's liquid, wheat plants. I'm sure you've got many others in whichever country you live, but go for those that have got hyaluronic acid in them and that have got glycosaminoglycans. These are hydrophilic molecules that are absorbed through the skin, and they're essential vaginal moisturizers. Then there are lubricants. Lubricants are just what it says, lubricants. Not terribly keen on them, but they do help. Some of them, like Multigyne, have got probiotics. There are variants which have got probiotics in them, which improve the vaginal microbiome, because this also changes with the menopause. KY jelly is just a lubricant, and others. But anyway, they might help really reduce discomfort, particularly during intercourse, and so it should be thought of. New on the block, right? The new boy on the block are these biocellular masks, which we have some experience with, and which are quite interesting. And basically, these are propeller-shaped masks, as opposed to facial masks. These are vulval masks, but the principle is the same. They've got a large number of anti-inflammatory molecules with them. They've got hyaluronic acid here and some palmitols here, which also stimulates epidermal growth. Anti-inflammatory, lack of estrogens increases your immune response, so you're more liable to have a chronic sub-inflammatory type of condition happening. You're more prone to that. Hyaluronic acid increases with is a hydrophilic molecule which increases the water content in the dermis itself and in the epidermis, and this combination leads to these masks being applied for between 15 to 30 minutes. And although they are a bit messy, it's a very clean preparation, and the whole preparation dries up in no time at all, and it's very, very, it does relieve a lot of soreness, itching, and dryness in the skin. And we're doing reasonably well with them. Here is an illustration, which is not as nice as Professor Simoncini's, but it just gives you an idea that what happens that without estrogens, you get an increase in transepidermal water loss. The hyaluronic acid, as an example, is one of the glycosaminoglycans, which is reduced, and this reduces therefore hydration. The skin is inelastic, the collagen bundles are thinner, and you get an increased inflammatory response here. And if you, with use of estrogens or with use of these moisturizers or the mask, for example, you get a decrease in transepidermal water loss, and you will see that the epidermis itself is thicker and looks actually healthier under a microscope. The collagen fibers themselves have got an increased tone, particularly with estrogens, but they do actually block with fluid. And the dermis itself has got a much higher water content because the glycosaminoglycans content are increased. Now they're increased because you've introduced them, or they can be increased through estrogen replacement therapy, where the fibroblasts themselves will then manufacture both collagen and glycosaminoglycans. And there's an improved inflammatory response because there's these subtle insults to the epidermis and dermis gives this itchy feeling, and you've got a vicious circle where you've got inflammation, itching, so on. And then you start getting fissures and infections. So that's the role of moisturizers and these masks. And we also use them post-laser, for example, maybe daily for 7 days. We find that we don't really need that. One application is enough, and then maybe want to apply another mask after 7 days. And we get relief, say, once every month to maintain results. But we let the patients be best judge as to how often they want to use masks or moisturizers. With Rachel, for example, with these old moisturizers, we ask for an application to be done at least once a day for the first 14 days, then twice to 3 times a week, depending on need. Talking about hormones now, which is the mainstay of treatment, we're talking about vaginal estrogens first. And there are various vaginal estrogens around, tablets or cream. I have to emphasize, please do not confuse the ones that are used on skin and the ones that are used on vulva. They've got to be water-based, not alcohol-based. If you use an alcohol-based estrogen on the vulva, you're going to get extreme burning, itching, and soreness, okay? So avoid using alcohol on the vulva. I know that you all know this, but please remember that, okay? Because we've been caught out time and time again with that. Now, if you're going to use local doses, it's effective at much lower doses. We have to remind you as well that if you've had a hysterectomy, you do need vaginal estrogens, because even if you do use systemic estrogens, you seem to get a better result with a combination of the two than with systemic use alone. So hysterectomies, please consider using vaginal estrogens as well, as opposed to in addition to the systemic use of estrogens. If you do have a uterus, or if you decide to just use local therapy, see how you go with vaginal estrogens, then decide whether you need to add systemic use or not for vaginal and vulvar atrophy, but for other reasons as well. So there's cream, there are pessaries, there is an estradiol ring, which is very interesting, low dose estradiol. There's also, I have to remind you, an estradiol ring, an UVA contraceptive, which is also in ring form, but this particular one gives you a natural estrogen, vaginal estrogen tablets that have come down in dose from 25 milligrams to 10 milligram tablets now, and they're available in more than one formulation actually. And these tablets, once again, are once a day for 14 days. Then once the initial estrogenization has been achieved, you go down to once, twice a week or 3 times a week. There are the serums coming on the market. We've known for a long time that tamoxifen, for example, or raloxifene do relieve vaginal dryness taken orally. There is an oral serum called ospemifene. It is taken daily. It's an agonist for vaginal epithelium. It's an antagonist for breast. So in theory, this preparation will decrease the incidence of breast cancer. But we've seen that this happened with estrogens alone. We've seen it happen with raloxifene, for example. It does relieve painful sex symptoms and moderate or severe GSM. Ospemifene is licensed for vaginal atrophy. It can be taken for as long as 6 months, and then we can stop it and start as necessary. It's still, however, ironically, they all carry this. Contraindicated women with breast cancer are at risk of breast cancer, which is very strange, because raloxifene has been shown to lower breast cancer by as much as 50 and 60%. And there's another serum called lasofoxifene, which is still in development. We've done very well with presterone. I wish that presterone was more available, more readily available everywhere, because the vaginal application of the DHEA, and Professor Jannazzani has done lots of seminal research on DHEA, but this has been shown to ease painful intercourse. DHEA is the master of sex steroids, as you know. It's one of the precursors of testosterone and estrogen, and is therefore very, very useful. But in its own right, vaginal application has been seen to relieve painful intercourse, and also to be of help in VVA in general, in tissue dryness. What about systemic estrogen therapy? Well, this has been shrouded with problems because of the false stories of the misinterpretation of WHI. We now know that this is not so, especially if you don't have a uterus. The use of estrogens do not increase your incidence of breast cancer or breast cancer mortality, even up to 18 years after use. But anyway, systemic estrogen therapy does have a therapy. It's a mainstay. It's a multisystemic treatment. It will treat various other organs like skin, bones, brain, and of course, in early menopause, its main purpose is to stop early menopausal symptoms like hot flashes, sweat, and so on. But vaginal dryness actually resolves very, very quickly with systemic therapy. This is dose-related. You might want to use pills, pellets, or gel. A discussion of risks versus benefits need to occur. Remember that vaginal use of estrogens will not relieve bone density problems, for example. Very rarely we relieve hot flushes, but it's better than nothing. And in fact, even from the million women study point of view, for example, vaginal use of estrogen in the current doses is not even, not even considered to be HRT. Whereas here we've got systemic estrogen use, which is a different kettle of fish, with or without progesterone, depending on whether you have a uterus or not. And if you have a uterus, you've got to decide which is the best progestogen to use. But on its own, without a uterus, very, very safe treatment. And you need to have a discussion, especially if it's used early on. This is also very useful prophylaxis against osteoporosis and cardiovascular disease. Once again, contraindicated in patients with breast cancer or high risk of breast cancer, and this can be calculated independently. Risk can be calculated nowadays. These are some references that might interest you. Okay, let's go to laser now, which is another new boy in the block. Well, it's not so new, but it's becoming increasingly useful. It's used for vaginal atrophy, bladder, postmenopausal urinary symptoms, stress incontinence, i.e. when you've got a problem with your valve, with urethra. The treatment instability, we still don't know. The jury is still out on the treatment instability. Vulval itching, atrophy, and lactic sclerosis. There's now quite a number of publications, including a recent one, a climacteric by Marck Brincat, showing that it's of use in atrophy and also in superficial dyspareunia, for example, caused by vaginal atrophy. We use the YAG laser here, but we've got equally good results with carbon dioxide lasers, for example. And here we've got dystrophies. Dystrophies are different to vulvar vaginal atrophy. Dystrophy can be a precursor to vulval cancer, which is very, very serious, but also leads to a lot of misery, a lot of itching. Like in sclerosis, for example, is intractable. We used to resort to simple valvectomies in the past. Very little treatment actually works other than surgery. And even if you do surgery and have a skin graft, you might get lichen sclerosis or some vulvar dystrophy developing again, even in your skin graft for some reason or other. This is not completely understood. However, erbium reglase is giving a way out because there's statistically significant improvements in itching, pain, bruising, excoriation, scratches, that is, and hypopigmentation. We can get this blanching of your vulva due to persistent itching. So, lichen sclerosis, back against the wall, we're getting some good relief in cases. And this lichen sclerosis is not necessarily related to hypoestrogenism, not necessarily related to menopause. It can happen even in younger girls. So really, I'm just including this just for completeness sake. So here's another paper with carbon dioxide laser, this time showing that symptoms of VVA are improved. Other papers with lichen sclerosis creates an ablative effect with CO2 laser. Erbium laser does not cause an ablative effect because its penetration is only 0.1 to 0.3 millimeters. It's less destructive, but the results are similar. We can get relief, even reversal of pathological changes in lichen sclerosis using laser. And this is, for me, quite surprising because we were brought up with this, impossible condition to treat, lichen sclerosis, easily recognized, and we used to resort to surgery, testosterone gels, all sorts of steroids, multiple steroids. If you use too high doses of steroids or long term, you end up having very thin skin, more abrasions, more itching, and this is laser is an alternative, we think. So here's another paper, and we're looking at other vulval pathologies. Vitiligo is another very annoying, intractable condition. Very often it starts on the vulva and vagina. The combination with 5-FU might reduce the progression of vitiligo, but we have to wait and see. So, in conclusion, skin is skin wherever it is. And skin collagen, the collagen in skin is collagen wherever you find it. I did not go into blood vessels, obviously, or our work on cartilage, but basically all collagen is modified by the menopause and is modified by hormone replacement therapy, the mainstay of treatment for this particular condition, for menopause-related changes in your skin, bone, carotid, or wherever. There are subtle distinctions, obviously, more to do with the presence of estrogen receptors or the type of collagen present, but the responses are more or less the same. It is suggested that skin collagen changes reflect skin collagen changes elsewhere, and this has now been shown. And there are other options in improving skin thickness and collagen, such as serums, T-sex, which I have time to talk about. T-sex, we really refer to products like Livial, Tibolone, Tibolone, which is really undervalued in many places. And now there are combinations of serums and estrogens around, which are very, very promising, but they still need to be further investigated. The vulva itself is very underreported. We need to ask people more about it because they are suffering unnecessarily. It's underdiagnosed, very widespread, and impinges on the quality of life and general health of women. And the VVA and GSM reflects also the general states of connective tissue in general in the woman. But really, we've got to look for this because there are very important and practical treatments which are relatively easy to use. And when treated conditions, several options exist, ranging from local treatments, non-hormonal treatments, moisturizers, vulval masks, hormonal or laser options. So we've got a whole, and as Professor Simoncini showed, we've got a whole battery of options that can be used, and we have to individualize treatment depending on the person. And one thing the WHI made clear to us is that we need to individualize treatment, and treatment depends not only on the individual, but on the period of time when you are considering treatment, be it a 50-year-old woman or a 60-year-old woman. All this has got to be individualized. Such treatment can be used in combination, actually. There's no reason why you can't use vaginal pessaries, for example, tablets with laser. There's no reason at all. And treatment should be individually designed, as we said, depending on her clinical history, risks, and response to such treatment. The last conclusion is that laser is gaining credibility. 50% of women do complain of vaginal dryness, and yet only 5% or so report it. And we want to consider laser as reported by NAMS, and I don't have a plug for laser, but I'm just including it here for completeness sake. And this, I hope, wraps up this particular presentation. Thank you, Andrea.
Thank you, Mark. Beautiful presentation. And then I invite also Tommaso here. And then when we start, we have received a huge series of questions. It is attractant, and still we have the same participant present there, still more than 260. Then we are a huge group. Then
very good.
Very good.
We will ask our speaker to put the responses. First, an anonymous asked to Tommaso, could we prevent pelvic floor dysfunction in aging women?
This is a big question. Preventing pelvic floor dysfunction, it depends on what we are discussing about. So if it's urinary incontinence, if it's urgency urinary incontinence, whatever we do to keep the muscles fit with pelvic floor rehabilitation or pelvic floor training, muscle training is going to prevent. Hormonal treatments and wise use of things like mannose and cranberries can prevent infections, which could prevent urinary urgency. I don't think we can really prevent prolapse, like anatomical dysfunction. That is really in the genes and in the bodily characteristics of a certain woman. So we can certainly advise for women not getting too much weight, which is an important risk factor at the time of menopause and aging. But other than that, I don't think we can do anything that effective.
Thank you very much. And then is now one integrated question from Fred Naftolin, I think for Mark. Fred is asking, actinic effects on skin include free radical damage. Estrogen in a ROS link, should sunscreen contain estrogen or SERM?
Always very clever ones from Fred Naftolin. Well, exactly. He's right. There is oxidative reactions. To my mind, I don't know of any sunblocks or sunscreens that do contain estrogens or SERMs, but there are certainly a lot of moisturizers, a lot of skin creams that contain phytoestrogens. There are a lot of them on the market. Roche and Nivea, and Vichy in particular have got, I should be mentioning names, sorry. But I do know that there are a lot of cosmetic companies that use our work, and this was a surprise to me, to put phytoestrogens in their skin creams, in their face creams, So this happens already, but we don't have any, as far as I know, with actual estrogen in them. They do, but phytoestrogens are very, very commonly used in face creams.
And then also, Fred, is a question, this I think for Tommaso. Please address genitourinary symptom of the menopause in premature menopause with ovaries and after ovariectomy.
Well, first of all, it's a pleasure and an honor to receive a question from Professor Fred Naftolin. Hello, Fred. I hope you're doing fine. Hello. Thanks for the question. I think it's very similar to the menopausal symptoms in early menopausal women. They are different than the symptoms that we encounter in 50 years and above women undergoing menopause. So in younger women, it's much more difficult to find cystitis, painful bladder symptoms. It's more common to encounter troubles with orgasmic function or to sensitivity. But it's very variable. I don't think there's any reliable study assessing systematically the function of the pelvic floor in women undergoing premature, particularly early premature menopause. And in my personal clinical practice, I've not really seen major pelvic floor dysfunctions in these very young women. That is probably because most of them have not undergone pregnancy, they've not delivered, so their pelvic floors are actually healthier in terms of muscular function, nerve function, and also this neurogenic inflammation, this inflammatory stimulus requires time. So if it's too early, the bladder and their lower urinary tract are still okay in terms of how they're structured. So that's probably why they don't develop the same symptoms, or at least symptoms with the same intensity.
Thank you, Tommaso. And then for Mark, we have two questions. You mentioned several times in your slide, Mark, that some treatment have not the indication of when women had a breast cancer or have a high risk of breast cancer. And then Michelle is asking, what form of HRT do you recommend in women with an history of breast cancer? And Laura Pilatek, she asked what we can do for the women with a history of breast cancer, hormonal and triple negative, and genitourinary syndrome of the menopause. Can we propose something for them? Please, Mark.
Well, we have the raloxifene work, and raloxifene has been shown to be very effective in lowering the incidence of recurrence, also in estrogen-positive breast cancer. So we have 3 different studies from raloxifene showing that the incidence of primary breast cancer is much lower using raloxifene. So certainly raloxifene predates ospemifene in having been shown to be useful in vulvovaginal atrophy and in preventing also osteoporosis, right? So I would tend to say raloxifene is safe. There is no reason to, raloxifene is tamoxifer's cousin. Tamoxifen has been shown to be safe even in preventing secondary breast cancer. And the results are staggering because they go between 50 and 80%. So I think raloxifene is safe, certainly. Moisturizers are always safe, and laser is always safe. But as an aside, should we consider using vaginal tablets, the 10 microgram ones, I think, twice a week in women with estrogen receptive breast cancer? I think this is a very controversial area, and I've known oncologists who, simply because their patients were on aromatase inhibitors, particularly women who had vaginal hysterectomies, they had women who were suffering so badly from vaginal atrophy that they themselves consented. They asked me to give them vaginal tablets, vaginal pessaries. And I said, well, you're the ones who've created fuss, you give them. And sure enough, they did. So there are a few women. And there's been a number of studies that have been stopped, like Danish study, where the use of estrogens was used in women who've had the estrogen receptor breast cancer, simply because these women, particularly who are on aromatase inhibitors, have got so many symptoms. So yes, consider serums, consider moisturizers, as we discussed, consider laser, or vaginal masks, which are moisturizers as well. But in your desperate cases, a nice balance, a good discussion, and a risk-benefit analysis needs to be carried out. And there might be a place for also recommending vaginal pessaries, the low-dose vaginal pessaries that are in use.
Thank you, Mike. And then now we have 2 questions for Tommaso from Zdravko Kamenov. He asked, how long after menopause could be initiated the topical estrogen therapy, and are there time limits for its further use? And also, is there a place for topical testosterone gel in vulvovaginal atrophy?
Okay, no, thank you for the questions. There's no limitation for the initiation of topical estrogen therapy. You can initiate whenever you want. There's no time limitations. It's a safe therapy. So there's no reason why an older woman should not be submitted to this therapy. There's no limitation as well in terms of duration. So as we all, I think, tell to our women, if they want to, if they have advantages, and if they feel better under vaginal estrogens, they should not stop. because if they stop, they go back to where they were before. So, and there's no reason why stopping it. So you can do it up to 90 years of age. So it's really no limitations. Testosterone. Testosterone has really little investigation on the treatment of VVA. We have information on the treatment of vulvar lichen sclerosus. There we know that there is some effects. There's preparations with bioidenticals. Pharmacists prepare the testosterone in the galenic forms, particularly in creams. But I don't think there's any evidence for the use of topical testosterone in the vagina right now. It needs to be investigated. There might be some rationale similar to what we have for DHEA, which, however, also provides transformation to estrogens in the vagina, but it's not been investigated. Okay,
Mark, you want to add something?
Yeah, because I forgot to mention the triple negative breast cancer, which was mentioned by the earlier
in the question.
Questions. And really, there, I'm afraid we are stuck because we have to just recommend moisturizers, or vagina moisturizers, or laser, or something topical. But we can't recommend hormonal or serums in the triple negative breast cancer cases. Okay. Simply because we don't know the answer, really. We will wait and see what the vitamin D receptor antagonist will say, but even then, we really don't know.
Thank you very much. And then it's another question from Catherine Katzer to you. Could you please show and please say the ingredients of the vulva mask?
Well, we had it on a slide earlier. I think you should have to look it up. But basically, you've got hyaluronic acid. You've got a combination of an anti-inflammatory, a hydrophilic molecule like hyaluronic acid, and permitic oil, which is useful in the epidermis, will make your epidermis softer. So those are the three main ingredients, plus a vector to get them through the skin. Always, it's got to be a water-based preparation.
And then now we have an anonymous for Tommaso. Dr. Simoncini, would you have any tips and tricks for the management of symptomatic menopausal genitourinary syndrome?
Yeah, absolutely. Tips and tricks. This is a very broad question. First of all, be very proactive. So try to win all the resistance that women still have due to the WHI storm. So there's really no reason why not using local therapies, local estrogens. And in most instances, there's actually no reason why not using systemic hormone replacement therapies. These are safe therapies that bring more advantages than disadvantages in healthy women, so women without problems. So the first issue is really to be very optimistic and be able to transfer the reality of the science and to overcome the perceptions, the misperception that they have. Second, try to use, particularly when you want to approach a woman with a very severe VVA, you have to use preparations that are very, with the simplest components as possible. Because very often when you start a local therapy, women have burning feelings, they have itching. So the therapy that will help them throughout time at the beginning might induce some unwanted symptoms. So for instance, it's very useful to use gels for vaginal estrogens as a starting therapy, because they're very gentle. They have an hydration ability that is superior to the tablets or to suppositories. And then for the continuation of the therapy, when the vagina has changed and there's more lubrication, then anything will probably be okay. So it's really the preference of the woman to choosing the preparation that is more likely to be used consistently and over time. That is the winning strategy.
Thank you very much. And then now to Professor Marck Brincat from Aura Bartaskiene from Lithuania. there was not clear for me about vitiligo laser treatment. Vitiligo is more cosmetic problem. Can we differ leukoplakia vulvae versus vitiligo during inspection, or we have to consider patients' told symptoms?
I mean, vitiligo is maybe a cosmetic problem, but it's probably an autoimmune problem as well. So you can't just dismiss it and say it doesn't matter. And the treatment for it is very unsatisfactory. Now, leukoplakia is different. You get thick skin, itchy skin, and sclerosis is different. So yes, you can differentiate. And certainly, if you are in doubt, it is our practice to take a biopsy, a small Gillette 3mm biopsy, and the pathologist can distinguish. But I mean, there are lots of differences. Leukoplakia has got a thick epidermis, thick keratin layer, deeper dendrites, which are flatter and broader. The dermis itself is very deranged, full of eosinophils, full of mast cells. It looks inflammatory. Leukoplakia as such, vitiligo as such, she's right there, has got very little histological change. The skin is very often thin. It's a melanocyte problem, but nevertheless, it seems to be an autoimmune problem. It's very embarrassing, particularly it starts going off onto your skin and your face and whatever, and people are very self-conscious. So, you know, I included it for completeness' sake. There's just maybe 5FU right now, injections with 5FU, which might limit it. But since our biggest handicap with vitiligo is we don't really know the etiology. If we knew the etiology, then we could target treatment better. But definitely not to be confused with leukoplakia or like sclerosis or dystrophies, which can lead to vulval cancer, which could be pre-malignant conditions.
Thank you. And then a question from David Bosoni for Professor Simoncini. Nowadays, according to the literature and in your personal expert opinion, which is the role of the new energy-based therapies, laser, radiofrequency, high focus and ultrasound, and so on menopausal pelvic floor?
This is a very interesting question. So we need to distinguish lasers as compared to everything else. So radio frequencies or high frequency ultrasounds. So lasers have some evidence on vulvovaginal atrophy, which shows that there are feasible options to address atrophy of the vaginal wall in postmenopausal women. And this is independent of being a woman with a menopause after cancer or without the cancer. So in any woman, in any vagina, there would be a response. For the pelvic floor, it's investigational. There's a lot of rationale for looking into that, but there's so far no convincing evidence that laser therapies will be effective on prolapse prevention, prolapse treatment, not even on urinary incontinence. So I think it's fair, since these energies are used commonly in private practice, not offering these treatments on a payback basis, so not selling this treatment for these indications so far. We need to establish if they're effective or not, otherwise they're used. For radio frequencies, there's really no data, so they need to be investigated.
Thank you very much. And then now it's okay. Andrea Gresano, she's asking which is better topically, testosterone or DHEA for postmenopausal women. The problem is that we have no comparative studies with testosterone, which is not present in most countries, and vaginal DHEA. Then we need comparative studies for that one. But a question for Mark, yes, Mark, is estriol cream contraindicator for post-endometrial cancer?
Post-endometrial cancer. Well, once again, I mean, it is, yes, really. But I think with proper counseling, with a proper risk-benefit type of counseling, you might come to some conclusion. I could never really understand why estrogens are contraindicated in endometrial cancer, those ones. And the reason is that endometrial cancer is an estrogen-sensitive cancer. And it also happens to be very close to the vagina. And one of the commonest recurrence sites for endometrial cancer is the vault of the vagina. Please remember that. So I'm afraid, in my book, I would be more worried about using an estrogen vaginal estrogen locally in an endometrial cancer, then I would be worried in using a stage 1 breast cancer estrogen receptor positive case, you know. You know, I think I'm afraid we have to say this is contraindicated at present, right? And just going back to the pelvic floor one, if I may, well, as we discussed in my lecture, it's a problem with loss of elasticity and the breakdown. So once you've broken down that pelvic floor, you cannot replace it back any other way other than surgery. And then you probably don't have the same functionality. You cannot restore a prolapse because the elasticity has gone. It's cracked. The horse has bolted, you know. so you can try and prevent it happening. And there are various ways how you can try and prevent it happening, as Professor Simoncini has said. But to try and correct a prolapse that's already happened because your elasticity has cracked, has broken, and reverse that is difficult.
Thank you. Tommaso, do you want to add something?
No, I think Mark said it wonderfully.
And then I have a further question about you. It's an anonymous. I'd like to hear comments from Dr. Simoncini. The study by Dr. Maria Grazia Matarazzo of the Gynecological Clinic University of Catania on the effect of the HCA on overactive bladder.
Oh, yes, thanks. I'm aware of the study. So this is a study on postmenopausal women with overactive bladder who were actually treated with local vaginal DHEA. And it was a study with questionnaires on basically frequency of voiding, function, and so. And the study basically showed that there was a reduction in the frequency of urinary leakages in women treated with the DHEA. I think this is a very interesting study, and it makes sense because vaginal estrogens are effective on overactivity of the bladder. So why should not DHEA be effective? Because DHEA is converted to estrogens. I think that we also have data on ospemifene coming from Pierluigi Benedetti Panici's group in Rome, showing that with a different concepts, a selective estrogen receptor modulator, you can also decrease overactive bladder symptoms in women. So I think that what these studies are telling us is that how, in any way you reestablish some estrogen receptor signaling in the vagina and in the lower urinary tract, overactive bladder symptoms improve. We still need information on stress urinary incontinence. We are actually starting a study on DHEA for stress urinary incontinence with the use of urine dynamics. So we want to make it objective because I think Professor Genazzani knows very well since many years that the androgenic component of DHEA might be very effective in promoting an increase in the muscular response around the vagina and the urethra, which could be something that could be achieved in addition to what estrogen do on the vaginal microbiome. So I think it's very interesting anyway. This is a field for investigation.
Thank you. And then a question, Mark, from Fred Naftalin. A very interesting one. I put together the two questions. Please comment on the use of estrogen SERM in scarring and keloids. And the second question is, why does sex skin, then vulva and vagina, never form keloids?
Yes, yeah, right, okay. So, Professor Naftalin, thank you for that one. Well, there's also a lot of information around, okay? I just would like, the interesting point is that if you look at recent scarring, recent wounds in a pregnant woman, they have the worst keloids of everyone. Okay, so I'm sure you've come across women who've had a recent scar and got pregnant on their abdomen, and they get the worst possible keloids. So there is no doubt that an excess of estrogens, despite possibly having a corticosteroid effect, still causes serious keloids. So this is one, and whether we talk about, let's look at the wound healing side on the other hand, and there's a lot of evidence that wound healing is better in the presence of normal estrogen levels. So premenopausal women or women on HRT heal better heal better, their skin wounds heal better and nicer than women who are postmenopausal and who are estrogen depleted. The work of Ashcroft, Professor Nestor will remember that for sure. So this is it. And there's also, of course, a genetic component to keloid formation. There are some races who have worse keloids than others, and we know that as well. So when it comes to the vulval skin, it is also very interesting. And I'd like to ask Professor Naftalin, who's got a great brain, to reflect on why do women who have cesarean sections not have adhesions? This is a big puzzle because we know that the smallest intra-abdominal operation causes adhesions potentially, but with cesarean sections, when there is fluid, meconium, liquor, blood, everything, you very rarely get adhesion formation. And this is a puzzle. It's certainly related to high corticosteroid levels, high estrogen levels, whatever. But we have to think about it. A small cystectomy, ovarian cystectomy, get adhesions. Massive cesarean section, you don't. So this is interesting. When it comes to perineal skin, we have always been taught that, especially when doing an episiotomy, for example, why don't you get a keloid with an episiotomy? You get a scar, but you rarely get a keloid. The answer, we've always been taught, because the blood supply is so good. There is such a brisk blood supply that even in the presence of a birth that's just happened, potential infections, possible feces or whatever, you can stitch an episiotomy, and very rarely do you get a keloid. You can, with recurrent infections, get scarring, then you have to do a perineorrhaphy, but fair enough. But really, the perineum heals really, really well. And there was a study from Zimbabwe, former Rhodesia, which said, listen, don't go to too much trouble stitching your episiotomy, just put in a few mattress sutures, and that's it, and then you just as well as you're fine, fine this sort of suturing, whatever. So it was always put down to a brisk blood supply.
Thank you very much. I think we will discuss with Fred in Florence. And then now,
yes, a pleasure.
I have a last question from Corrado Altomare for Tommaso. And then he asked, since there seems to be less sensitivity of the blood there in elderly women, this accounts for the high incidence of undiagnosed urinary tract infection, which develops into sepsis oftentimes in long-term care facilities. Are there new guidelines for these facilities to follow, which will minimize these cases of severe urinary tract infection and sepsis?
Well, thank you. I'm not aware of specific guidelines for long-term care facilities to this extent, but this is a common clinical problem. And one of the reasons why it is so common to have sepsis in these elder women that are hospitalized in these long-term care facilities is the use of indwelling bladder catheters. That's the main reason. So I think there has been a major improvement in the materials of bladder catheters. So there's a lot of catheters that have coverages with biofilms that make it less frequent to have bladder infections, but it's not changed really the frequency of these events. The reality is that keeping women mobile, keeping them dry, so treating urinary incontinence with drugs or with surgery, it's much safer than using a catheter or using a pad that covers and keep everything wet for the day and facilitates infection. This is not very often done in long-term care facilities.
Then now we will have a final comment, and I would like to start first with Mark and then Tommaso. I would like that you give your final message on your topic to our participants who are still more than 220. Then, it's 1 hour and a half that you are speaking. Then Mark, give us your master message.
Well, I'll be very brief. Remember that connective tissue is connective tissue everywhere. The degenerative concept is the same. And that if you're going to talk about vulvovaginal atrophy and GSM, this is a debilitating condition ranging from vulval itching to chronic cystitis to pain on intercourse. It's a broad spectrum, but really, unless we professionals ask the right questions, we won't get the right answer. So this is an underdiagnosed, undertreated condition with treatment that is very satisfactory. There are lots of open questions, but there's a lot of treatment tailored to the individuals, and we should always look out for it.
Thank you very much. And then Tommaso?
Well, I think the main message is that urinary dysfunction is a part of the menopausal transition. So we need to be aware of that. So we need to have the ability to investigate that. So studying a little bit that part of a woman's pathology will help us provide more effective responses, therapeutical responses. And this is a big part of the success of a clinician. So particularly for those working in private practices, if you can solve a recurrent urinary tract infection or a postcoital bladder infection in a woman, you will be very popular because there's not that many gynecologists who know how to approach that, and the urologists don't read that. So it's really something that goes into your own interest, but mostly in the interest of your patient.
Thank you, Tommaso. Thank you, Mark. Thank you to both of you. This was a fantastic webinar from the International Society of Gynecological Endocrinology on hormone-dependent and independent aging of the pelvic floor, external genitalia, and skin. And then, dear friends, I would like first of all to remind to all of you that very soon, the 19th of January, we start with the menstrual cycle disorder from osteopathogenesis to diagnostic and treatment, which is an online course starting 19th of January and ending July 7th of 2022. Go in, and then this is a special effort of the International School of Gynecological and Reproductive Endocrinology. And please, can I have the next slide? And you will, the next slide is to announce you that who is the next webinar. The next webinar will be the 10th of February. And then together with Angelica Hirschberg, we will speak about DHEA as an anti-aging therapy, systemic and local effects. You will be very interested by that presentation. And this is a new challenging area of interest of the International Society of Gynecological Endocrinology. Please, next slides too. And then in the next slide, I remind you what Tommaso have already shown, that we will have our Congress, which will be face-to-face 11-14 May of 2022 in Florence. It will be the 20th World Congress of Gynecological Endocrinology, and I invite all of you to join us to send abstract. I remind you the scholarship, the important scholarship that we have. We offer to the best 50 abstracts sent by a young investigator, not only free registration, but also free accommodation. And then I am sure we will have a huge scientific event and we will enjoy all together. And then Tommaso and Mark, thank you very much for your time, for your dedication, for your input, and for the beautifulness of the discussion. I thank all of those who have participated in the discussion, who have sent their question, from Fred Naftolin, one of the biggest members of our board of the ISGE, to all the others who participate.